Okay, good morning, everyone. I hope I'm audible. Felix, will you confirm?
Yes, you're audible.
Okay, thank you. Thank you all for joining today's session on XYZ Disease Med. Today's session will be on multiple sclerosis. And before we start, I'd like to tell you a bit about what XYZ Disease Med is about. Then I'll introduce the speaker, and then we'll go on to have a Mentimeter session before the speaker goes. Then we'll have the session, and after that we'll have another post-session test. So my name is Nicholas Stam. I'm a level 6 medical student at the University of Nairobi, and so I'm going to start by introducing XYZ Med. So XYZ Med is a vibrant community of Kenyan medical students from multiple universities united by the mission to enhance medical education in Kenya. This initiative is driven by the need to create accessible, locally relevant, and tailored resources that directly address the country's unique healthcare challenges. The current medical education system in Kenya frequently depends on foreign resources, which may not always align with the local context. This gap may leave healthcare professionals less prepared and contributes to a lack of public awareness regarding various medical conditions. XYZ Med is bridging this divide by developing a wide range of educational tools, including relatable medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, etc. One such initiative is this CME series designed to promote peer-to-peer learning, as it's often our peers who can break down complex concepts into more understandable terms. Today's topic is multiple sclerosis, and our able speaker is Dr. Mariam Yusuf, who just recently earned her MBCHB, driven by a passion for advancing healthcare in the fields of neurology and oncology. With a deep interest in understanding neurological disorders and oncology, she aspires to make meaningful contributions to both fields. Beyond medicine, Dr. Mariam enjoys painting, traveling, and exploring different cultures. In her free time, she practices mindfulness through yoga. With her curiosity and compassion, she is committed to lifelong learning and making a positive impact on the lives of her patients. So before letting Dr. Mariam in, I'd like to share the Mentimeter for you guys just to have a pre-session check-in.
Stam, I don't know if it's just me, but we can't hear you.
Okay, so unfortunately, there's a bit of our age. So I think Dr. Mariam can start presenting. Welcome, Dr. Mariam.
Thank you. Good morning, everyone. My name is Dr. Mariam, and today we're going to learn about multiple sclerosis. So I hope we learn, and I hope we have fun. So I'm going to begin. Just a second. Can you guys see my screen?
Yes.
Okay. Okay, so the objectives of this session are, by the end of the session, you should be able to define multiple sclerosis, define its etiology, discuss the pathophysiology, expound on the clinical features, describe the clinical features, discuss its diagnosis, and state the treatment of multiple sclerosis. So we're first going to start with the definition. What is multiple sclerosis? Multiple sclerosis is a chronic degenerative disease of the CNS caused by an autoimmune process, specifically a type 4 hypersensitivity reaction, and it's normally characterized by demyelination and axonal degeneration, followed by subsequent neurological deficits. The cause, etiology of multiple sclerosis. So there are no known particular causes, but multiple sclerosis has been associated to be caused by an interplay between environmental and genetic factors. So the specific environmental factors that have been contributed to cause multiple sclerosis are specific viral infections, including Epstein-Barr virus, human herpes virus 6, low vitamin D levels, as well as smoking. And people who are exposed to this specific environmental factors and have and are genetically susceptible are people who have mutations in HLA-DR2 gene, and as well as females more than males, and people who are between the ages of 20 to 40 years, as well as Black population. So the pathophysiology. So in this case, I'm going to give a scenario. Let's say we're talking about a 25-year-old female, a 25-year-old Black female. So what happens? So let's say this female is exposed to human herpes virus 6, and she's already genetically susceptible. So once this antigen, which is the virus in this case, enters the body, the antigen presenting cell, an example of which is a macrophage, will attack it, and then it's going to present it to a T cell. So this process is going to start an inflammatory process, which will lead to production of cytokines and other pro-inflammatory molecules, as well as a T helper cells are going to be produced. So this antigens, in this case, the human herpes virus 6 can sometimes mimic normal proteins in our bodies, a process which is termed as molecular mimicry. And when this happens, the activated T helper cells, they pass through the blood-brain barrier and come into contact with oligodendrocytes. And remember, we said these antigens can mimic the structure of the normal proteins that you have in our body. Example, myelin basic protein, which is in myelin produced by oligodendrocytes. So once this activated T helper cells come into contact with oligodendrocytes, an inflammatory process is activated to release pro-inflammatory factors, including interleukin-1, interleukin-6, TNF-alpha, so this whole inflammatory process is going to increase the permeability of capillary vessels around the brain barrier. It's going to vasodilate the blood vessels as well as increase adhesion markers on the endothelial cells in an attempt to bring more WBCs around the inflammatory site. The whole inflammation process also produces cytokines as well as interferons, which will go to the circulation and cause more chemotaxis of macrophages and lymphocytes to the inflammatory factors, to the inflammatory site, sorry. So the lymphocytes that were brought to the inflammatory site are going to be converted to plasma cells, and it's eventually going to produce antibodies that are specific to myelin. So these antibodies are going to tag the myelin and stimulate the macrophages to even further engulf the myelin and like destroy the myelin. So now we have neurons or nerves with specific spots that don't have myelin. Okay, so the immune attacked myelin deficient spots on oligodendrocytes like heal and form scar tissue, which are called sclera or plaques. And since this process just doesn't occur on one neuron or nerve, it occurs on different neurons. This is where the name multiple sclerosis comes from, like multiple nerves with the scar tissue, which is called sclera or plaque. And around this process, after the inflammatory process, T regulatory cells from the circulation also crosses the blood-brain barrier to release anti-inflammatory cytokines, which include interleukin-10 and TGF-beta, which then regulates the inflammatory process and gives the oligodendrocytes time to remyelinate. But this process only lasts for a while. The next thing we're going to talk about is the types. So there are 4 specific types of multiple sclerosis. The first type and the most common type is the relapsing remitting multiple sclerosis. So in the relapsing remitting multiple sclerosis, we normally have a process where we have active disease and process of followed by a time where we have complete remission because of the regulatory cells that we talked about in the pathophysiology. So it's normally an interchanging process of active disease, remission, then we go back to active disease. This is the most common type. The second type is the secondary progressive multiple sclerosis. This type usually starts off as the first type that we talked about, relapsing remitting multiple sclerosis, and then it converts to a progressive disease without remission in between. Sorry, let me just put on my pointer option. Sorry. I hope you guys can see the pointer. So this is the one that I'm talking about, the secondary progressive that starts off as relapsing remitting and then goes on to become a progressive disease without remission in between. The third type is primary progressive multiple sclerosis, which starts with progressive disease and goes on without any remission or any period where we have less active disease. And the fourth and the last type, this is very rare, but it's the most severe type. It's called the progressive relapsing multiple sclerosis. So this one, we have progressive and relapse, but with no remission. It's like we have active disease, and then we have a period where we have an acute flare where even the symptoms become even worse, but it's not a remission, and it continues to go on with the on the same kind of baseline as it was before, but with no remission. So we have demyelination, acute flare-up, then continues to demyelinate. I hope that's clear. So the next thing we're going to talk about is the clinical features. So the first clinical feature and the most common type that we see in people with multiple sclerosis is optic neuritis. So the only cranial nerve that contains oligodendrocytes, myelinating it, is the optic nerve. So once the optic nerve is attacked, it manifests as decreased visual acuity, color blindness or color abnormality, relative apparent pupillary defect, which on in a clinical setting, it's referred to as a Marcus Gunn pupil. This is where when you do like a light reflex on the patient, instead of constricting, the pupil dilates. So that's the first clinical feature. The second clinical feature is bilateral internuclear ophthalmoplegia. So this one, I'm first going to play a video so that you can just understand what is going on, and then I'll come back and explain it. Just 1 second. I hope the video works. Okay. I hope you guys can still see my screen. Okay. I'm going to play that again. Ah, sorry, just a second. Okay. I hope you've seen the video. I think the audio wasn't playing, but I just hope you saw the guy's eyes, sorry, how they were moving. So in this clinical manifestation, another thing that MS loves to attack is something called the medial longitudinal fasciculus, which is a connection between the abducens nerve and the oculomotor nerve. So ipsilateral abducens nerve, which is, sorry, let me just, 1 second. Laser. Okay, I hope you guys can see the laser now. So this is the abducens nerve. It connects to the contralateral oculomotor nerve through the medial longitudinal fasciculus, as well as the other side. So left medial longitudinal fasciculus and right medial longitudinal fasciculus. So what this medial longitudinal fasciculus does is once it gets, okay, let me give another scenario. So a 25-year-old female comes to your clinic. You suspect they have MS, and you want to check if the gaze is working properly. So how this whole process starts, we're going to talk about the right eye first. So if you tell your patient to look to the right, the neuronal control of voluntary lateral gaze to the right starts in there. left cerebral hemisphere, which is the one that I'm pointing here. So you tell your patient to look right. So the control starts from the left hemisphere. So the left hemisphere sends signals to the vestibular nuclei. The vestibular nuclei sends more signals to the contralateral abducens nerve, which sends direct signals to the right lateral rectus muscle. And what is the function of the lateral rectus? Abduction. So the patient will look like towards this side. And once the lateral rectus is activated, since you can't just move one eye to the lateral, when you tell the patient, you can even try right now, when you tell someone to look to the right eye will abduct while the left eye will adduct. So once the right eye adducts, it sends signals down to the abducens and through the left medial longitudinal fasciculars to the oculomotor nerve, which sends signals to the left medial rectus so that it enables the left eye to adduct. I hope we're getting, you can ask questions after this if you didn't get. So let's say the person has MS, right? And this whole thing, this right and left medial longitudinal fasciculars are destroyed. So we get our signals normal up until the abducens. The abducens is normal. We send our signals to the left. We send our signals to the right lateral rectus. Our right eye is abducted. But now, when we want to send the signals back to the oculomotor to adduct the left eye, we can't because this whole pathway is destroyed. So this eye will adduct. Sorry, just something just popped up on my screen. This right eye will adduct, but the left eye is going to remain central. I tried doing like a drawing here. So this is what I was talking about. So the right eye will adduct, but the left eye is going to remain central. The same thing happens when you tell the patient to look left. The left eye will adduct, and the right eye is going to remain in the middle because our medial longitudinal fasciculars are not working. Okay. But when you tell the patient to look inward, let me just go back. So when you tell the patient to look inward, when you tell the patient to do like a finger to nose test, a convergence test, the patient will be able to adduct both eyes. Why is this? Because we can send signals directly from the oculomotor nerve to the medial rectus of both eyes without relying on the medial longitudinal fasciculars. This is why people with MS, they can converge their eyes because we don't use this pathway to converge. Okay. And the final one is when you tell the patient to look straight. Again, we go back to our image. So you tell the patient to look straight. We have our medial longitudinal fasciculars destroyed. So we have an opposed pull of both lateral rectors on both sides. So lateral rectors are working, but all other muscles are not working very properly. So we're going to have an opposed pull of lateral rectors in both eyes. So we'll have our eyes abducting both eyes. But this is in very severe cases. The abducens overfires with no opposition from oculomotor and it pulls the eye laterally. This is called bilateral extropia at rest. So the eyes look like they're, I think, compound eyes. They're called compound eyes or something. Yeah. So I hope that is clear. But if you have any questions, you can ask at the end. The third clinical manifestation is pseudobulbar palsy. So pseudobulbar palsy is, again, we have tracts coming down from the cerebral cortex, so cortico bulbar, going to the brainstem, and the whole pathway, they innervate different cranial nerves, which include cranial nerve 5, 7, 9, 10, 11, and 12. So MS also loves attacking this corticobulbar tract. Okay, so corticobulbar tracts are myelinated by oligodendrocytes, and demyelination causes an upper motor neuron lesion. An upper motor neuron lesion because the tracts are coming from the brain going downwards. So this is what is called pseudobulbar palsy. And when they're demyelinated, they can't send signals to the different to the different cranial nerves they were sending signals to or innervating. So each of the cranial nerves that was receiving signals from the corticobulbar tract is going to be affected. So cranial nerve 5, oculomotor, will have decreased chewing, brisk jaw reflex. Facial nerve, absent facial expression. Cranial nerves 9, 10, 11, so we'll have dysphagia, dysphonia, and hyperactive gag reflex, as well as cranial nerve 12. We'll have the speech affected because we'll have a spastic tongue, which will present with dysarthria. The fourth clinical manifestation is that MS also demyelinates other nerves in higher centers. Examples of these nerves that it demyelinates are neurons that release serotonin. So the person will present with depression and reduced memory. MS also loves attacking white matter tracts that are present within the cerebellum. And we know the function of the cerebellum is coordination and balance. So this person will present with ataxia and intention tremors. Another thing that presents in people with MS is Lemaitre sign, where when you tell the patient to flex their neck, it creates an electrical sensation or pain which radiates to the extremities, so the hands. And when you tell the patient to flex their neck, they're going to feel pain in their hands and their legs. And lastly, I think we have one more clinical presentation. We have Uthoff's phenomenon. So this is whenever you increase the body temperature, for example, when the patient takes a hot shower, the neurological manifestations that were already there, they worsen. So if the patient was dizzy before, they get even dizzier. If they were weak, if they had sensory changes or visual disturbances, like all the symptoms worsen, but this is only temporary until the body temperature goes back to normal. This is because higher temperatures decrease the action potential on already demyelinated nerves. So it's going to worsen the symptoms that are already there. And lastly, we'll have, apart from the brain and the tract that we talked about, MS also loves attacking the spinal cord, and it attacks different tracts on the spinal cord. So we can start with the dorsal column. We know the function of the dorsal column is proprioception, fine touch, and vibration. So it's going to decrease. It also attacks the lateral corticospinal tract, and we'll have an upper motor neuron lesion. So we'll have weakness, hypertonia, hyperreflexia, and positive Babinski, as well as decreased autonomic nervous innervation. So we'll have urine and fecal retention. It also attacks the lateral spinothalamic tract, which function in conducting pain, temperature, crude touch, and pressure sensations, as well as the spinocerebellar tracts, which deal with proprioception and balance. So we have ataxia. So a common triad that people with MS present with is called the Charcot's triad, where the patient presents with nystagmus, dysarthria, and intention tremors. So that's all about the clinical presentation. We now move to the diagnosis. So the diagnosis, we first start with the clinically. So the patient, there's something called the McDonald's criteria. So this is, we say dissemination in space and time. So the symptoms, dissemination in space is like, say you do an MRI. Today the lesions are on the brain, tomorrow they're on the spinal cord, like, and the other time you're like following up, the lesions, like, they're on different places in the CNS. And dissemination in time is they have, let's say, an attack on the optic nerve, like this month, and then another attack like that, like the same place, but just different times. I hope that is clear. And then after you clinically diagnose through the McDonald's criteria, you do the first line investigation you want to do is an MRI, MRI of brain and spinal cord with and without contrast. So on P1, you're going to see hypointense lesions, and P2, you'll see hyperintense lesions. And when you do an MRI with contrast, the contrast enhances only the acute lesions. So you'll be able to better visualize the acute attacks that are happening or have just recently happened. So on MRI, you'll see this white lesions, either on the brain or spinal cord, and they're called Dawson fingers, as you can see here on the where I'm pointing at, as well as on the spine. So they're called Dawson fingers. And so I think normally, like most people just to do, once you diagnose it clinically, you do your MRI and you go straight to a lumbar puncture. So when you do a lumbar puncture, the CSF is going to contain antibodies, specifically IgG. And when you do electrophoresis, you're going to see oligoclonal bands, which are formed by the specific antibodies that are in the CSF. You can also see different cell types, which is pilocytosis, including lymphocytes and macrophages. But apart from those two tests, you can do a visually evoked potential, where you visually, like, you stimulate the optic nerve with a visual stimulus, and then you'll see the conduction potential down the optic nerve is reduced. And finally, how do we treat it? So we can do both supportive and definitive management. So for supportive, all the symptoms, if the patient had upper motor neuron lesions, they had increased spasticity, you can give antispasmodic agents, including baclofen. If the patient had reduced sensations or paresthesia, you can give gabapentin or pregabalin. If the patient is depressed, you can give antidepressants. You can give vitamin D supplementations, because you remember in the etiology we said this is one of the factors, environmental factors, that are associated to cause MS. And for the definitive management, for acute exacerbations, you give the patient high-dose corticosteroids, or you can also do plasmapheresis. And then for long-term treatment, you can give glatiramer, which is an immune modulator. You can give interferon beta or monoclonal antibodies, including alemtuzumab or rituximab. And I am done. So I just put a quote from the Quran that says, "And whoever saves one life, it's as if he had saved the whole humankind." I hope, I guess that motivates you to do better in terms of being a doctor. So thank you. I'm done.
Yeah, thank you so much, Dr. Mariam, for that insightful session. Do you want to do the MCQs?
Okay, so I can do that.
No, like I thought you had like in your slides. It's fine. Because we had a few questions that we wanted to pose to the audience from Kahoot. And then after that, we'll have the Q&A session. Okay, so I'd kindly advise everyone to go to kahoot.it and then put the game pin shown there. So I'm going to give it a few minutes for more people to join, and then we proceed. Okay, I think we can now move on to the first question. So remember, the faster you answer, the more points you get. So what is the primary pathological feature of multiple sclerosis? Destruction of peripheral nerves, demyelination of CNS neurons, decreased CSF production, formation of neurofibrillary tangles. Oh, okay. Yes, so most of us do demyelination of the CNS. And our leader is 123 with 872 points, followed by NM and Khadija. So we move on to the second question. What is the function of interferon beta in the treatment of MS? Increases myelin production, suppresses the immune response, reduces inflammation, repairs damaged neuron, stimulates oligodendrocyte proliferation. Cases is answered, suppresses the immune response to reduce inflammation. And NM just overtook 123. Move to the third question. What is a common initial symptom of multiple sclerosis? Chest pain, vision problems, hearing loss, frequent urination. Yes, this is very common, vision problems. And NM is still leading. So multiple sclerosis affects the central nervous system. Which part of the CNS is usually attacked? Neurons, myelin, plaques, vertebra. Okay, myelin, and most of us got it correct. Okay, so my name is Unbeatable, leading champion for now. Which therapy is often recommended for treating slowly progressing MS? Corticosteroids, ACTH, corticosteroids and ACTH, or none of the above? Okay, none of the above. Wow. And NM just got overtaken by just L. Which of the following is not considered a risk factor for developing MS? Family history, living in high altitude regions, excessive exercise, and vitamin D deficiency. Okay, excessive exercise. Okay, so our king or queen is back to opposition. A person with MS who wants to have children should be aware that MS may affect her pregnancy in what way? A miscarriage is more likely, labor and delivery may be more risky, the baby may develop birth defects, symptoms may fade away in late pregnancy, but get worse after childbirth. Symptoms may fade away in late pregnancy, but get worse after childbirth. Okay. Now we have a new leader. 1, 2, 3. It's a tight race, yeah, clearly. Which symptom is described as Lamette sign in multiple sclerosis? Sensation of electric shock traveling down the spine when bending the neck, a stabbing pain in the chest, sudden onset of muscle weakness, severe headaches triggered by stress. I think we've just seen this. Sensation of electric shock traveling down the spine when bending the neck. Wow. And 100% record of that. Good job, Dr. Marian. And 1, 2, 3 is still leading. So the following is considered a secondary symptom of MS: optic neuritis, depression, muscle spasms, numbness of the limbs. Depression, yeah. One, two, three again is our leader. Can't wait to see who wins eventually. So which age group is MS most likely to strike? Children under 12, adults aged 65 and older, adults aged 20 to 40, or it is not age specific. Adult age 20 to 40. Okay. Now, in third place, we had NM. Second place, Anan. And the king or queen of today's CME. 1, 2, 3. Congratulations to 1, 2, 3. Could you tell us your name on your, please, on your title? Please unmute if you can. 1, 2, 3. Okay. Congratulations, either way.
Thank you.
Who is it? Okay. So I want to check if there are any questions in the chat. So Eugene McCory is asking, what's the life expectancy for the patients with multiple sclerosis? I think I'll pose that to Dr. Mariam.
Hi, Bakari. Thank you for the question. So the life expectancy, I don't think I would say there's a specific number for like specific years for the life expectancy. But I think the average would be around like 30 years, depending on like how well the treatment is going, as well as the complications that are going to develop from it. But I think in general, I wouldn't say there's a specific like number of years that a person is expected to live. I think it just depends on the complications and how well the complications are being managed. I hope that answers your question.
Thank you so much for that comprehensive answer. I'll give around 1 minute for any more questions that are there. Feel free to type on the chat box and I can read them, or you can unmute if you can. In the meantime, remember to follow us on social media, our Spotify podcast, YouTube channel, and also participate in our ongoing study. Just a few seconds before we bring this to a close, in case anyone has a question or you need any clarification. Okay, it seems there's no question from the floor. So thank you so much, Dr. Mariam. At least from now, I can be sure I won't be roasted by Dr. Kwasa in the 7B ward. Thanks to you. Just this topic on multiple sclerosis.
Thank you, everyone. I'll share the presentation with you, maybe, if anyone is interested in having the notes.
Okay, thank you so much. I'm seeing our final question has come up. Faisal is asking, what's the most common cause of death in patients with MS?
Just a second. Okay, I think again, I would just go back to the complications, but I think the most common causes of death in people with MS are infections, especially respiratory and urinary tract infections, and conditions related to advanced disability and immobility, since like I think almost every other nerve, which of course innervates like muscles and stuff, are affected. So I think I'd say RESP and urinary tract infections, since we're affecting both our CNS and autonomic nervous systems.
Okay, thank you so much, Dr. Mariam. Once again, I want to thank you all for joining today's session. Today's continuous medical education series, and hopefully it's been able to demystify multiple sclerosis for you and made it simpler even as you go to revise on the topic. I feel like it's going to be much easier. Thank you so much, Dr. Mariam, and we really appreciate you taking your time and coming to discuss this very important topic in our medical education curriculum with us. For the rest, I think we can bring the CME to a close. Hope you have a lovely long weekend ahead and hope to see you next week, same place, same time, in the next continuous medical education series. So thank you all.